This segment is on patient prioritization. Now, this is a pretty important topic as a nurse, and it's something you really need to understand before taking the NCLEX, because you will get patient prioritization questions. This is something that you're going to use not just on the NCLEX, but every day, multiple times a day when you're working on a unit as a nurse. And you need to understand that what they're looking for on a patient prioritization question is that they're either looking for who is the most stable, or they're trying to establish who is the least stable. And they can come at this concept a couple of different ways. So if they're asking you who is the most stable, these are going to be questions that look like, who would you consider discharging today? Or who would you assign to the new graduate RN? Or they may ask you, who would you assign to a nurse who's floated to your unit from labor and delivery? Another classic way that they're going to assess this is to ask you, who would you assign to the LPN? So that's assessing who's the most stable. Then they may also be trying to figure out who is the least stable or who is the most unstable. And they're going to ask you this by asking you, who would you consider transferring to the ICU? Or who should you consider paging the doctor about? Or who would you go see first after receiving a report? So I'm going to break this down by giving you some words that you can look for, whether it's in the question or whether it's in the options you have as responses to that question. And these words will help rank the different patients based on their level of stability. Now, why do we need a stability framework model like this in addition to the ABCs? Well, I'm sure you've had a question like this before that for patient prioritization where the ABCs failed you. And the big challenge is, what happens when you're given 4 patients to prioritize and they all have airway problems? You know, I work at a big academic medical center, and we see patients from all over the place, and I work on about 16 different units, and one of the ones that I pick up on regularly, though, is a cardiothoracic surgery unit, where we see a lot of patients with lung transplants. So if you have 4 patients, all of whom had lung transplants, they all have airway problems. But which one are you going to see first? How do you prioritize those patients? Well, you could go on to breathing or circulation, but if there's nothing else differentiating those, how do you start to rank them and prioritize? Another place that ABC starts to fail is because it doesn't take into account whether something's chronic or acute. Here's a good example. Say you have comparing an airway problem to a GI problem. If that's the only information you have, sure, you can use ABCs. But what happens when I tell you that airway problem is somebody with chronic COPD? Well, they probably had that for a long time, because that's what it says. It says it's chronic. It's not a new situation for that patient. They're used to having COPD. And if I told you that the GI problem was appendicitis, so you have a patient with acute appendicitis, you don't have appendicitis for weeks or months or years. You have it for a day or two, and you're hurting. So you have acute appendicitis and you have chronic COPD. Well, which patient are you going to go see first? Which one are you going to give the priority to? Hopefully you're going to say, I want to go see that patient with acute appendicitis first, because the chronic COPD, that's just what they live with. That's their baseline. So you can see where if you went with ABCs, you'd have got wrecked, because you would have said airway supersedes GI, but in reality, it's much more complex than just ABCs, which is why you've likely missed those questions previously, because you relied solely on ABCs. One thing you need to be careful about before we get in the list of words that are going to indicate whether the patient is stable or unstable is a list of distracting things that you're going to see in the question or in the answers. And these are things like age. The patient's age is totally irrelevant, okay? Just like if it gave you a gender or the color of their skin, you wouldn't treat them differently, right? So a 2-year-old is not more important than a 56-year-old patient, okay? Don't fall into the trap of paying too much attention, or any attention really, to the age. The only time age is an important factor is when you're talking about, say, like a preterm infant versus a term infant. But if it's a 2-year-old versus a 56-year-old, pay no attention. And then obviously the gender is totally irrelevant. It's not something that you need to really pay attention to. So you just cross that right out when you're going to answer these questions. They're also going to give you a diagnosis or some symptoms, and those are important. You do want to pay attention to those. The most important part, though, are the modifying phrases about that diagnosis or set of symptoms. So I'm about to give you a list of words or modifying phrases that you can use to establish whether the patient is stable or unstable. Let's start with modifying phrases or words that will indicate that a patient is unstable. So number one in the unstable category is use of the word unstable. So if it says in the question or in one of the responses that the patient is unstable, then you should consider them unstable. Right? I know that seems kind of obvious, but don't overthink stuff. If it says it right in there, take it for what it says. Okay, don't overthink questions. Number two under unstable is an acute illness. Acute illnesses are more unstable or are less stable than chronic illnesses. So if you have two patients, one with an acute illness and one with a chronic illness, we're going to place a higher priority on the client who has the acute illness. So when we talk about differentiating between a chronic illness and an acute illness is something that we expect this client to have resolved within about 3 months with medical intervention. If it's going to be longer than 3 months and something the patient's going to be managing for an extended period of time, then we're going to consider that a chronic illness. And the third thing that should indicate that a patient is unstable is if it indicates that they're post-op less than 12 hours. If somebody had a heart replacement or a lung replacement or some major surgery yesterday or 2 days ago, you should consider them stable. But if it's less than 12 hours ago, even if it's something basic like appendicitis or a knee replacement, you're going to say that patient is less stable because they had their surgery more recently. The fourth thing that's going to indicate that they're unstable is if they went under general anesthesia. General anesthesia meaning they sedated the entire body, not just a portion of the body. So somebody having a knee surgery who gets completely sedated as opposed to having some kind of nerve block that will just affect the knee or leg. So general anesthesia is more unstable. Number 5, if they have changing assessment findings, so if the question says that they have a change in vital signs or a change in level of consciousness, that's somebody who is unstable and needs to be monitored more frequently. Number 6, if they use the phrase recently admitted, and this should make sense to you because we don't admit stable patients, right? There's a reason that they are staying in the hospital and that we're not just sending them home. So if you're working in the emergency department and somebody comes in, you treat them and you get them stabilized, you send them home. You don't admit them. We're keeping them admitted because they are unstable and they need to be monitored. Number 7, the phrase newly diagnosed should indicate that they're more unstable. This is going to be something that is going to be in the question or in one of the answer responses. And then number 8, lab values that are rated C or D. And if you haven't listened to the lecture yet on lab values, C-rated lab values are critical, essentially, and D-rated lab values are deadly. So lab values that are rated C or D. So have a listen to that lecture. That portion will make a lot more sense. Here's a good way to summarize all of the patients who are unstable. One thing you really want to look for is things that are not part of that patient's expected disease process. So these patients are experiencing the unexpected. All right. So if somebody is 3 days post-MI and they're having some angina, well, that's not weird, right? That's what you expect of those patients. Now, if you're sitting on an airplane and the stranger sitting next to you starts telling you that they're having this crushing sensation in their chest and this pain, well, that's not part of that person's expected experience. So, while the angina patient who's in the hospital and a couple of days post MI, yeah, we're concerned about that, but that's not a crazy situation. So take that into consideration. It doesn't really matter if the situation sounds really bad. If it's what we expect of them, then that's okay. But if it's something that's unexpected, then we're definitely going to place a higher priority on that. Now, here's a list of words that you're going to see in questions and in responses that indicate that a patient is stable. All right. So we just talked about what makes a patient unstable. So those are going to be the people that the unstable patients are the ones that we're going to consider transferring to the ICU, or we're going to call the doctor about, or the one that we want to go see first after receiving a report. Now, who's the most stable patient, right? Who are we going to assign to the LPN, or who are we going to assign to the new graduate RN, or who might we consider discharging? These are words that are going to indicate a patient is stable. Number one, use of the word stable. For the same reason as unstable. If it says they're stable, they're stable. So don't start to read into this. This is where some test takers will fail, is because they'll overthink a question. So if you're already an LPN and you're going to take the RN exam, or if you've been a tech or a patient care aide somewhere, have previous healthcare experience, you're almost at a disservice because you have all these other experiences that you're drawing off of. So it'll say that the patient's stable, but you'll think, well, I had a patient like that and, well, they weren't stable. Or, yeah, I know that, that patient might be stable now, but they could easily go south on me. If it says they're stable, they're stable. Don't overthink it. All right. So, number two, a chronic illness is more stable than an acute illness. All right, so chronic, again, anything over 3 months, give or take. And these are patients who are not going to have their disease or their condition resolved within 3 months or so of standard medical treatment. If somebody's post-op over 12 hours, we're going to consider them stable. We've had some time to observe them. Their bleeding's under control. Their respiration's under control. Hopefully we've got their pain under control. And they are essentially stable after 12 hours, even if they've had a major surgery. Number four, if somebody's had local anesthesia, that's more stable than somebody who had general anesthesia. Right? Number five, somebody who has unchanging or consistent assessment findings. So if the patient has, even if something's crazy about them and they would otherwise be really sick, but it says that they have stable vital signs or an unchanging level of consciousness, then we're going to consider them more stable than somebody who has changing assessment findings or a change in level of consciousness. The sixth thing that indicates that a patient is stable is use of the phrase "to be discharged." Well, for the same reason that when a patient's admitted that we consider them unstable, when we're discharging a patient, well, we admitted them because they were unstable. So the only reason we're going to discharge them is if we feel like they're stable. We don't discharge unstable patients. The seventh thing are lab values that are rated A or B. And again, if you haven't listened to that lecture yet on lab values, A lab values are acceptable, essentially, and B is borderline. These are potentially out-of-range lab values, but aren't things that are critical to that patient's condition. So next to the little asterisk there in the under the stable category, these are patients that are exhibiting what you expect to see from them. All right. So, you don't want to prioritize solely based on the severity of a patient's symptoms. You want to consider, again, the expectation level of a sign or symptom for that patient's given disease or diagnosis. So these are patients experiencing what we expect. So the biggest difference between an RN and an LPN, and this is based off of the Nurse Practice Acts in all the different states. And the Nurse Practice Act indicates what a nurse is and isn't allowed to do in any given state. It says things like a nurse can do this, but not that. Well, the differentiating factor between an RN and LPN is that LPNs are supposed to be taking care of clients who have a stable condition or are in an unchanging environment. It's not necessarily that they're giving weaker meds or that they're not taking care of really sick people. The people they're taking care of might be very sick, but they're not changing. So an RN is supposed to be taking care of patients who are experiencing something different than what we expect them to experience, or are taking care of patients who have a changing condition. Right, that's the biggest difference between an RN and an LPN. Yeah, there's skill differences, skill sets, like starting IVs and pushing medications and that sort of thing that are going to differentiate between the two, but that's the big picture. LPNs take care of stable patients. RNs take care of unstable patients or patients who are experiencing a change in their condition. Now, there's certain things that are always considered unstable, regardless if it's what we expect them to be experiencing or if they've been experiencing it for a long time. Okay, things that are always considered unstable. Number one is hypoglycemia, regardless of how long they've been hypoglycemic. If somebody's hypoglycemic, they are unstable. Right? For general rule in the NCLEX, you can consider somebody with a blood sugar under 70 as being unstable. Right? A patient who is hemorrhaging is considered unstable, even if they've been hemorrhaging for a while. Now, there's a difference between the words hemorrhage and bleeding. Bleeding is what happens when you cut your finger while you're cooking in the kitchen. Hemorrhaging is a major loss of blood and is considered a medical emergency and is always considered unstable. Bleeding, not necessarily. Don't read too much into bleeding. It's not a major issue. Hyperpyrexia, over 104 degrees. Now, the NCLEX is a vocabulary exam as much as anything. So it may say they have an elevated temperature, but it also may say hyperpyrexia. Right? So hyperpyrexia over 104. Even if they've had this for a while, we're still going to consider that unstable. And then lastly, this should make common sense, but if a patient is pulseless or breathless, we're going to consider them unstable, even if that's what you expect of that person or if they've been experiencing that for a while. Always unstable. So it's time to apply all of these different rules. And what we're going to do is look at each of the answer responses and go through all the different words in each response. So go to A, and if it has the word unstable and it has the word changing and it says recently admitted, well, those are three things that indicate that that patient's unstable. If the next patient has a chronic disease and is post-op over 12 hours, but was newly diagnosed. Well, that's two stable indicators and one unstable indicator, right? So that's not going to be as critical as a patient that we had in situation A who had three things that were unstable. Something might look like a pretty bad situation, but when you start giving it different values based off of our stability framework, it might not rank up that high because it's going to be using words that indicate that the patient is more stable. Now, you will need some certain tiebreaker situations, and that's where you can go back to ABCs and use your common sense. If something just feels right, don't be afraid to go with it. And you can, like I said, you can use the ABCs. It is a valuable tool, but you can't rely solely upon ABCs. One other thing you can use as a tiebreaker is to consider, and this is at the bottom of the lecture sheet here, is that the more vital the organ, the higher the priority. And this essentially expands on the ABC concept because the number one vital organ is the brain. It doesn't really matter how your airway's doing if you don't have a brain that's intact. So number one is brain. Number two is lungs, which is essentially, airway and breathing. Number three is the heart, which is your circulation in the ABCs. And number four is the liver. It's harder to transplant a liver than it is a kidney, right? Kidney transplants happen all the time, and lots of people have just one kidney or they have a third one added, which is kind of an interesting thing. I work on a renal transplant unit fairly regularly, and they when they give you a new kidney, they don't take out your old ones typically, unless there's something major going on with it, polycystic kidney disease, something like that. They're going to leave your existing kidneys in and add a third one. So they put that up on the anterior part of your body and your abdomen. So kind of interesting. So number 5 is kidneys. And number 6 is pancreas. And then 7, 8, 9, those are just going to be, kind of up to you and to your judgment and your critical thinking. Lots of people live without their appendix. Lots of people can, live without multiple feet of their intestines, or without their colon, or without, a leg. There's a lot of things that you can live without, but, your brains, your lungs, your heart, your liver, your kidneys, and your pancreas are pretty critical organs and stuff that's necessary for you to sustain life. A lot of the rest of the stuff that's not on that list isn't as big of a deal. Now, there's one other kind of prioritization that you're going to need to know, and it's about which drug do you give first. So that's also asking you a prioritization style question. And what you want to consider, here's the big concept, is that you want to give the drug that stabilizes an unstable patient. So that's what's most important, is stabilizing an unstable patient. That's the one you're going to give the highest priority to. In summary of the patient prioritization lecture, I hope you can now use this stability framework to answer your patient prioritization questions, and use this in addition to the ABC prioritization framework and to your common sense. So blend the three together, and I think you're going to have a lot more success on patient prioritization questions.